Hey everyone, I figured I'd go over this waveform in a little bit longer format because there's a few things to talk about that I think this case highlights. While there wasn't a specific correct answer, I think there were some things that are worth talking about at least. So, prompt was a mid-50s-year-old man, but ultimately unknown sort of person, just sort of found down at the bus stop. Altered, medics on the scene administered Narcan with no response. Vital signs were stable. Sugar was greater than 600 on AccuCheck. So can presume that the patient was resuscitated in the ambulance somewhat and brought to the hospital. So given fluid en route to the hospital for the sugar of 600, and then in the ER had some seizure-like motion which lasted for some period of time, needed non-rebreather, ultimately dropped his SAT to about 70%, and then decided to intubate the patient. And during intubation, there was some concern that there could have been aspiration, so the ED team wanted to start out with some low tidal volume ventilation in order to sort of avert ARDS because of the aspiration. So at this particular hospital, they used PRBC, so it led to lung protective settings with about a 6.5, 7 cc per kg of body weight total volume that was started on the patient. As you can see here with PRBC, sort of as usual, what you're getting in this, what we should see, and the way that, if you remember, the way that we like to sort of think about this stuff is what should the waveforms look like, and then what do the waveforms look like. So remember, PRBC being a pressure-based mode, what it should look like, and again, I'm drawing with the pen, so forgive me for any sort of misdrawings. The pressure should rise to some number, which in PRBC is going to kind of be set by the algorithm of the ventilator. It'll give a couple test breaths to see what kind of pressure it needs to deliver a volume of 340, remembering that as the patient starts to interact with the ventilator more, these figures could be misleading for the vent. So, but nevertheless, what it should look like is the pressure rising to some number, staying at that number for the instatory time, and then depressurizing on expiration down to the PEEP. What you should see in the flow, if the patient's passive, remember, is sort of this natural decay, which the flow increases during inspiration, the first part of inspiration, so the peak inspiratory flow, and then through natural decay, so as you move through inspiration, the pressure's equalized, therefore the flow gets less and less, ultimately when might come to zero, so it sort of looks something like this maybe, very crudely, because I'm drawn with the mouse, and then we cycle off into expiration, and then your volume should look sort of this sort of exponential rise, because the most flow and volume happens in the beginning of the breath because the pressure differential is the biggest, to some number, which would in this situation be our set total volume, and then into expiration. And I think it's pretty clear that we don't see that for a few reasons. One is that the pressure seems to be very, very low. It's almost like the PEEP. And if you look at the peak inspiratory pressure, it's in the single digits, which should automatically raise some red flags. Now, some people might say, you know, these little upswings in pressure at the end, like there and sort of there, but not as high, but there also. And that doesn't necessarily represent the pressure during inspiration or the ventilator supplying pressure. What that represents is the patient pushing out against the ventilator, trying to get it to cycle. Because in this waveform, there's sort of multiple dysynchronies, which not the least of which include delayed cycling. So that's what you'll see in delayed cycling. That's a sort of a hallmark of it, is that in the pressure waveform, there's sort of a spike towards the end, which is a rise in the pressure towards the end of the breath. That could mean that the patient's trying to sort of push against the ventilator to get it to cycle into expiration. And you sort of see that represented in the flow waveform. So let's take this one, for example, the second one. Here the patient's just essentially breathing in this whole time, so just pulling flow almost in a straight line, but then towards the end of it just blows out tremendously to try to get the ventilator to cycle. So, you know, linking this with what you think is going on with the patient, which, you know, I hadn't given you a lot of background or story, but I think what you could maybe presume is that there's some degree of metabolic instability going on. So if patient's altered, the sugar is greater than 600. I think things like DKA, HHNK have to sort of be in the forefront of your mind. So if you're going to intubate the patient, our post-intubation settings are going to have to be similar to what the patient's doing during the pre-intubation period. So if the patient's breathing heavily, aggressively because they have acidosis, now you're not going to know that sort of out of the gate because you only have a certain amount of history and information. But Certainly with the sugar over 600 in the story, you would think that maybe DK is playing a role. So you would need to think about your settings after you intubate the patient. I think the issue is from some online discussion is that if the patient has acidosis or severe metabolic derangements and you have to intubate the patient for some reason, even though we try to avoid that because we know that intubating the patient just doesn't really fix the problem and ultimately leads to probably more problems. But in some situations, you need to do that for whatever reason, altered mental status, aspiration, whatever the cause is. And there's this presumption that you have to sort of go above and beyond what you can with the mechanical properties of the lung, let's say, for a passive patient. Now, for an active patient, I think it's a little bit different. Now, in this situation, the patient's active. And I think overall what we'll discuss is sort of the active patient. But remember, in the passive patient, expiration in the passive patient is completely passive, meaning what you're stuck at as far as a rate goes is dictated by your time constant. So if you intubate a patient with severe metabolic acidosis and they're paralyzed, you can't just make the rate 30 and the volume 500 because you have to try to match what they were doing pre-intubation. That's not going to work. It's not going to work because your rate's going to be too high at some point based on the mechanics, based on the time constant. So me personally, if I have to intubate someone who has metabolic acidosis and I'm going to have to squeeze every single last ounce of minute ventilation I can out of them, what I do in the post-intubation period is get a time constant, figure out my max rate. I try to sort of cheat below the max so there's a little bit of a fudge factor, let's say. So if I do the time constant and the max rate's like 28, I wouldn't make the rate 30 because I know I'm going to auto peep. And then that is a whole other set of issues. And remember, on this podcast channel, at least, we try to do things that are safe as far as, so the ultimate goal of mechanical ventilation is avoid death and torture. The way that we avoid death certainly is by trying to abide by the goals of ventilation and oxygenation. Nevertheless, if I have to ventilate someone who is passive with severe metabolic acidosis, the first thing I'll do is get a time constant, because from the time constant, I'll be able to figure out a rate. Once I have a rate, I'll go about 1 or 2 breaths below that just to give me a little bit of fudge factor, and then I'll figure out a volume. It's probably going to be somewhere in the 7, 8, 9 ml per kg range. Remember that the size of the total volume doesn't dictate whether you're going to auto peep because it's not in the equation. I've talked about this ad nauseum, and if you have any questions, you can always ask me where to find that content. But generally speaking, you can fit a 7, 8, 9 ml per kg breath if you have the appropriate settings as far as the rate goes based on the time constant in a passive patient. Which makes ventilating patients with acidosis who are passive not really that difficult, because you could probably put them on whatever mode you want, PRVC, even if you wanted to, because it's kind of irrelevant because they're not participating. So you'd have to figure out what the rate's going to be. I do that based on the time constant, so I make sure I don't give them auto peep. And then I figure out a total volume based on what my plateau pressures are. So as far as the safety goes. So if I have a 7 ml per kg breath and my plateau is 30, I have to think twice about whether 7 ml per kg is sort of safe in that patient, which could mean a whole different set of circumstances, especially in the setting of aspiration or pneumonia or whatever. But I think you get the point. If you're going to intubate someone with metabolic acidosis, sometimes you have to, and that's fine, but you have to make sure you're safe with the ventilator. How are you safe? You ventilate with safe pressures by checking plateau pressures based on your volume. You're probably going to have to go a little bit higher, 7, 8 ml per kg, to satisfy your minute ventilation need. And you have to ventilate with safe rates as to not give the patient auto peep. And how do you do that? You do that by the time constant. Or at least that's how I do it, and I think that's the best way to do it. But for this patient, eventually they sort of woke up and now they're participating in ventilation, obviously, because they're incredibly tachypnic. They're at a respiratory rate of 30, 31. And we have their rates, we have their volume at 340 because remember, we were worried that maybe they aspirated. We want to do some lung protective strategy, so we put the ml per kg a little bit lower, about 6 ml per kg. But since this is a pressure-controlled mode, remember the patient can pull as much flow and volume out of the circuit as the patient wants over the inspiratory time. The only thing that's different with pressure with PRVC is that if the patient does that, the amount of support they're going to get from the ventilator is going to be decreased. So it's going to be less and less and less as they pull more and more and more. So now your peak pressure is not even, the ventilator is barely doing anything at this point because the peak pressure is so low. And now we didn't really intubate the patient for, let's say, a pulmonary issue. So they probably don't need a lot of inspiratory pressure to help them, but they're under a tremendous metabolic load for whatever reason. In this case, it could be DKA. There is no sort of answer to this because I just made it up, to be honest with you. But what I want you to start thinking about is it's not about solving the issue with the ventilator. It's about sort of using the vent as your support as you fix whatever the condition is. So in this situation, I would argue that the vent's probably not adding support in this situation because it's not adding any additive pressure to help the patient with their metabolic demand. In fact, in some ways, it's probably torturing the patient because instead of providing pressure to help the patient breathe, it's actually decreasing the amount of pressure support as the patient breathes more and more. So I would argue that this is sort of counterproductive. So you consult the ICU team, and the ICU fellow says, put the patient on pressure control with the lowest driving pressure to protect them from ARDS. So hopefully the driving pressure comment was triggering enough. So remember, in pressure controlled modes, whatever the amount of pressure above your PEEP, which is what you set, is sort of what's helping the patient during inspiration to take a breath in. Some people call that pressure control, some people call that inspiratory pressure, some people call that delta P, some people call that driving pressure. We'll talk about driving pressure last, but the rest of the pressure sort of verbiage is kind of irrelevant in some ways. The confusing thing is that people who call this driving pressure are presuming that the patient's passive, and the presumption is that the flow goes to zero. Because without those two criteria being met, you don't know what the plateau pressure is. So if the patient is not passive and they're pulling more flow and volume out of the circuit, then their mechanics would dictate, meaning more flow and volume out of the circuit than their compliance would dictate based on a differential in pressure. So PEEP as a starting point and then adding pressure on top of it, which is your delta P or your pressure control or your driving pressure, and getting a volume. If the patient's active in that, then the amount of volume they're getting is not connected to just that delta change in airway pressure, because we didn't factor in the delta change in intrathoracic pressure from the diaphragm contracting. So that's the first issue. So I just put driving pressure there to sort of purposely confuse people, but ultimately want to bring up the point that when we talk about driving pressure in pressure control, really in any mode, but pressure control, the thing you have to be cognizant of are people referencing driving pressure in pressure control as the set inspiratory pressure. If they're doing that, the thing you have to make sure of is that the patient is passive and the flow is getting to zero. If those two things aren't true, then the patient's plateau pressure is not what you think it is. Therefore, the delta P or the driving pressure isn't whatever you set. So that's the first issue. In this situation, so we get some more history back, some more information. So the UA is positive for ketones, VBG is 7, the sugar is 1100, white cell is 15, platelet 78. So I just made all this stuff up. But what it's sort of pointing us in the direction of is like this DKA picture. So what we know in DKA is that the patients have a tremendous drive to breathe. So now think about what we've done. We've intubated a patient with DKA, and then I'm going to make the argument that the patient could have COPD. I'm going to make that argument because of a few reasons. Number one is that you're getting a tremendous volume, like 700, without that much change in pressure. So you're going from a PEEP of 5 with a inspiratory pressure of 15. And the patient's active now because we set the respiratory rate at 15, but they're breathing 18. You know, whether they're sort of triggering every breath or not, or they are breathing at this point. So what you see is if we would say the driving pressure is 15, that would probably be false. It would be false because even at end inspiration, the flow hasn't gone down. Now, is that because the patient has emphysema and their compliance is really great? That could be possible. Is it because the patient is participating in breathing, so they're dropping their diaphragm and creating more negative pressure sort of from the bottom, so they're getting more flow and volume? That could also be possible. Nevertheless, we don't really know what the driving pressure is because we don't really know what the plateau pressure is, or we can't sort of assume it based on the waveforms. Now, you could do an inspiratory hold and figure out what the plateau pressure is, but if you're in a situation where you don't have an inspiratory hold button, pre-hospital people, let's say, two things can be true at once. So you could not know the driving pressure, but the other thing is that you could know that the driving pressure is not tremendously high. So the driving pressure is not like 30, because if the driving pressure was that high, you wouldn't get any flow because you're only pressurizing to a peak area pressure at 20. So I think the things you could take away from this are, if you're ventilating with sort of low pressures, you can assume that you're not having incredibly elevated driving pressure. because your plateau pressure is probably not going to be super duper elevated. Could it be super duper elevated if the patient's pulling in a tremendous amount of volume and flow and making the plateau very, very high? I guess that's possible. But just from here, what I would say that this is sort of giving more of a higher compliance situation because you have a tremendous amount of flow initially over the inspiratory time, which is about, 0.9 seconds, let's say, and you still have this flow going at the end of inspiration, meaning that there's still a pretty big delta in pressures. So if you still have a pretty big delta in pressures, that only kind of happens in one situation, in a few situations. The first would be if you have a really high compliance situation. The second would be if the patient's taking in a tremendous amount of flow. That being said, the way that this looks, the curve, if they were sort of really sucking down, should be more sort of kicked out. We've seen that before. With this, it's sort of more straight. So I don't know how much the patient's really sort of sucking in very hard on the circuit to get flow. But based on sort of this flow curve not being super duper kicked out, I don't know if they're working to breathe incredibly hard, let's say. So the things that would worry me about this are, it's sort of giving the feels that it has a high compliance situation. The patient's getting a lot of volume for not a great amount of delta in pressure change, at least from the ventilator side. So we're only giving the patient about 15 centimeters of water and pressure change, and we're getting about 700 ml. Could that be normal? And maybe like a super tall person, I guess it could be normal. But these would just be the things I'd be looking at. The other thing is, I do think that there's maybe some degree of auto peep here, at least from the last one. There's a little bit of a volume loss, and that has to do with because the patient starts pulling up and then triggers a breath. The patient starts pulling up probably right here as the pressure starts to dip sort of downward. So if you remember from before, we call that delay trigger. So what delay trigger could be due from is from a couple different things, but one of those things is auto peep. So, and then there's some evidence of like dynamic hyperinflation because the flow curve goes below zero here, insinuating that there's kind of like volume that's trapped in from a previous breath that we didn't get out, which we know because in the previous breath there's a air leak. So there's volume that should have come out that didn't, so it's probably still in the lung. So on the subsequent breath, it starts to come out. So now the patient has some dynamic hyperinflation, meaning that in the previous breath there was some gas trapped, which is sort of the definition of auto peep. So what I mean is that when I look at this makes me think a few different things. One is that the compliance is high. Number two is that there's some degree of auto peep. Number three is that there's some degree of dynamic hyperinflation. Now, as it relates to metabolic acidosis, remember, when we think about the goals of ventilation, we have generally three, which is keep the pH around 7.2, keep the plateau pressure less than 30, and try to limit the amount of auto peep or eliminate it altogether. So sort of very specifically geared to limiting auto peep. In this situation, I think we're hitting our plateau pressure goal. There might be some auto peep. Certainly the pH goal is not going to be within reach just yet because if the patient has DKA, they have some other process that's generating acidosis. So in metabolic acidosis, as you ventilate metabolic acidosis, you cannot sacrifice ventilating with safe pressures to try to achieve your pH because you will never be able to do that. Or if you're able to do it, it will be at the expense of the pulmonary mechanics. And the one way to make this situation much worse is to give the patient a pneumothorax. That would be much worse. Or to make them have hemodynamic collapse from increasing the rate too much. So when you're in this situation where you have a spontaneously breathing patient, let's say now, and they have a respiratory drive, what I like to do, or what I try to do, is sort of just mitigate the harm of the ventilator. So when they have metabolic acidosis with a high respiratory drive, it's going to be hard to limit the amount of volume. 700 cc's in this situation, let's put it at the higher end. Let's put it at like 10 or 11 cc's per kg. Is that high? Yes. Does it make me nervous about volume trauma? Yes. Can I do anything about it? Not really. Because the issue isn't the ventilator, right? The issue is that the patient has DKA. So I would be served much better if I took care of the patient's DKA and then tried to sort of affix the ventilator the best I could to the patient and not reverse. Certainly not trying to increase the rate or the volume more because I can't increase the volume. I can increase the volume if I increase the delta pressure, but then he's going to be pulling in 900 cc's or 900 ml, which it does get sort of dangerous at some point. And the thing that you can't do is just sort of override this patient's rate. It's hard to override a patient's rate if they're breathing spontaneously with the ventilator. If you wanted to do that, you'd have to sort of sedate and or paralyze more. But again, remember, you're going to be at that point at the complete mercy of the pulmonary physiology as to not give them auto PEEP with the vent. So I think in this situation, the best thing to do is try to make the ventilator work as best as it can for the patient. How do you do that? You put them in modes that give the patient a little bit more control. Pressure control, pressure support. Some people wanted to switch off of pressure control to pressure support because it allows spontaneous breathing. So remember, the difference between pressure control and pressure support is not really that much, or not as much as you would think. Certainly in pressure support, we don't set a baseline rate, whereas in pressure control, we do. But besides that, and besides the cycling mechanism, pressure control is time, and pressure support, it's percent decay and flow. Besides those 2 points, there's really not a big difference between pressure control and pressure support, right? You have a PEEP, you set an inspiratory pressure, you set a percent FiO2, and that's basically it. So for me, certainly with a patient who's just intubated and has other things going on, I like having the backup rate of pressure control. I'll put it somewhere lower than their intrinsic rate just to get the vent out of their way. So if they're breathing at 18, I'll probably drop that respiratory rate down to like 14. That way the vent doesn't sort of trigger 1 or 2 breaths based on sort of the time period. If the patient doesn't get 15, but has maybe like, a few more breaths in a different time period, but a few less breaths in another time period, then the vent's triggering sort of intermittently because it's trying to achieve that 15 breaths per minute goal. Nevertheless, I do switch them into pressure support sometimes to see if it looks tremendously better. I don't find that it looks that much better all the time versus pressure control, especially if you have settings that are sort of appropriate. Maybe there's some like early cycling here, so the patient wants like a longer breath, at least in the second breath, which we could definitely play with the eye time and sort of make the vent fit the patient a little bit better. The last thing that I wanted to point out is, the patient in these situations, if they're breathing spontaneously, is going to drive their minute ventilation for whatever it's going to be. So whatever the patient sort of in their brain needs, they're going to do with the ventilator. It's just how much support you're going to give them, or how little support, or how much are you going to put them in harm's way with the vent. So the thing that I would look out for here, or thing that I would point out, is that in this situation, in the first vent screen, the MV here was 11.6, so about 12. When we gave the patient more control, when we put the patient on pressure control and made the breathing a little bit better, easier, let's say, because they're not breathing 31 times a minute, getting very small volumes, breathing less, getting bigger volumes, which I prefer because it takes that question of, is there a lot of auto PEEP out of the equation? Because here, there's definitely a ton of auto PEEP. I think you can probably, what they're doing essentially here is panting on the ventilator, just breathing in and out very, very fast. They're not going to be able to do that forever. They're going to build up auto PEEP. It's going to be harder to breathe. They're going to get more agitated. They're going to get more drug, et cetera, et cetera. So if you put them on something that's a little more comfortable, pressure control, taking a bigger breath, but breathing less, what you get, even though you have some auto PEEP still, I think what you're going to get is less auto PEEP, bigger volumes, but since I think this is more of a high compliance situation, I don't think your plateau pressure is going to be that big of an issue. But if you notice, the minute ventilation here is still 12, 11.9, close enough to 12. So you're getting the same minute ventilation practically, but with one ventilator screen, you're torturing the patient. With the other ventilator screen, you're torturing the patient a little bit less, ultimately trying to take care of the underlying condition, which is ultimately going to fix what's wrong with the patient and not the ventilator. But you can certainly make things a lot worse with the ventilator if you don't set your settings appropriately. So a little bit longer case discussion, I think, because of the nuance of ventilating metabolic acidosis, which is always a challenge and certainly not straightforward. So look forward to the feedback.